Our next speaker for this session is Dr. Ajay Kher from Delhi. He's going to teach us about CNI conversion to mTOR protocol.
The question answers would be at the end of the. Otherwise, timekeeping becomes difficult as we always exceed in the question answers.
Thank you. While the slides load up, so I'll be talking about CNI conversion to mTOR. The talk says protocol, but I don't have a protocol per se, so I'm just going to talk a little bit about my experience and kind of how I think about it. So while we wait, can I get a show of hands as to how many have a standard conversion to mTORs or start de novo with mTORs here? So at 3 months or 6 months, routinely convert to mTORs. Anyone? None. Okay. None. Okay. Okay. So, what I'm going to talk about is why would you want to consider conversion to mTORs? Some benefits and pitfalls, how to convert if you are planning to convert, and then some conclusions. And as this is Mumbai, we will do it with cases. So I'll start with a 76-year-old male with a kidney transplant from February 2013. His end-stage disease was due to ANCA disease and had been treated with Cytoxan and prednisone. He also had inflammatory bowel disease with Crohn's, treated with infliximab and prednisone, and had undergone a colectomy, at which point he had been thought to be ulcerative colitis, but turned out to be Crohn's post-op, and had ileoileostomy as well. He had also had a stroke with right hemiparesis in 2005 and had aortic stenosis with a valve area of 0.95. With all his immunosuppression in the past, he had also had history of CMV, PCP, and C. diff as well. So he received an ECD expanded criteria donor in February of 2013. His donor and recipient typing is here. He had a PRA and he had gray zone DSAs to DQ7 and DQ9. He received induction with Solumedrol and Simulect. Even though he got a cadaver because of his past immunosuppression and infection history, we decided to give basiliximab. With an expanded criteria donor, he did develop delayed graft function and perinephric fluid collections. And by protocol, every 2 weeks, 1 to 2 weeks, we do biopsies till the graft function recovers. His first biopsy showed a 2A rejection for which he got steroid pulse. His second biopsy showed ATN with some hyaline arteriolopathy, which was thought to be due to tacrolimus, which is why the question of conversion from CNI to sirolimus was proposed and why we converted him to sirolimus. Post-conversion to sirolimus, a month later, he was able to come off dialysis with a creatinine of 3.7. So these creatinines are actually off dialysis. So his creatinine came down, 3.7, 3.9, started coming down. And then in 2 to 3 months later, we had to convert him back to tacrolimus due to severe proteinuria and severe pedal edema and nephrotic syndrome. So he then was continued on prednisone, tacrolimus back with MMF, developed problems with MMF due to diarrhea, had to get converted to AZA, and also required a TAVI for his aortic stenosis. But his creatinine post-conversion back to tacrolimus remained stable, and he did well. So another patient, an 18-year-old male with an ABO incompatible transplant in September of 22, with mother as a donor, ABO to B, rituximab Simulect induction, baseline creatinine of 1.27. That increased in February, so about 6 months into his transplant to 2.8. Biopsy showed ATN with no signs of rejection, C4D was negative, and he was switched to everolimus from tacrolimus. And now, a month and a half later, creatinine has decreased to 1.6. So what are the benefits of where or how do you want to consider mTOR inhibitors? So the first and foremost is that it gives you options and alternatives. So you have something more in your armamentarium to use when you run into troubles or toxicities. So as an alternative to calcineurin, if you have delayed graft function, or you have ATN, or you have TMAs that you are due to calcineurins or toxicities, you have an option to consider as well. The data does show that when you switch someone from calcineurin to mTORs, your eGFR does go up. by itself, whether that's helpful or not, the outcomes are not great on it. In theory, we've all seen the glomerulus on calcineurin and that grape, and so there's always that anxiety of putting people on calcineurin, so sirolimus and mTOR doesn't have that. The additional advantage is that it is an anti-proliferative, so its effect on skin cancers, Kaposi and RCC, where it's used for treatment as well. And so this is a picture from NEJM about a Kaposi on the first one is Kaposi on CNI, and then the Kaposi disappears on sirolimus. So those are kind of the benefits. What are the pitfalls? So the pitfalls are that you have a drug discontinuation rate of 30%. So anyone who's done protocol conversions of CNI to mTORs, whether at 3 months or 6 months, or even those who have done de novo, 30% of your patients who you converted from CNI to mTOR will come back to CNI. And the reason may be either proteinuria, edema, wound healing, lung disease, oral ulcer, cytopenias, or diarrhea, or a combination of these. And there is, whenever you convert someone to an mTOR, all studies have shown that there is a higher rejection rate. So those are kind of the pitfalls, which is why everyone in the audience is not gung-ho about it and hasn't been doing this as well. However, if you do have to convert someone, how would you want to convert it? So there are 2 ways of conversion. One is a gradual conversion, which is what I tend to prefer, unless you are forced with a TMA to do it in an abrupt manner. So usually I'll half the CNI, and for sirolimus, I'll use the same dose. So if you're on 1 mg BD, we'll start with sirolimus 2 milligram daily. If you're on everolimus, you can do 1 mg BD, or others can kind of do a lower dose than that as well to start off. You check a level, and for toxicity as well, you'll want to monitor them. The half-life for sirolimus is 60 hours, so you want to do 8-10 day kind of levels rather than doing it too soon before the plateau has happened. If the level is at goal, then you can stop the CNI, and you will need to monitor them clinically for edema and other side effects, as well as for proteinuria, kidney function, lipids for triglycerides especially, and CBC, because if you're on sirolimus, MMF with steroids, you are at a high risk for leukopenia as well. If you are planning to switch someone in an abrupt manner, you would want to maybe consider doing a load of sirolimus at 5 or 6 milligram, and then put them on 2 to 4 milligram daily dosing to kind of convert them quickly from a CNI as well. So how do I think about it? I don't plan for any conversion because of the toxicities that we've discussed and the fact that going back and forth really doesn't do good for our patients. Converting their immunosuppression back and forth gives us more headache and doesn't help the patient. I switch only if there is toxicity or intolerance for CNI, and if there are cancers where I think a sirolimus conversion would be helpful. Do prepare the patient for the possibility of conversion, because at 30%, this is not a small percentage. And you may want to either plan ahead and start them on a statin or an ACE inhibitor or an ARB in anticipation of the proteinuria or hyperlipidemia that they may get. Monitor closely post-switch for the steady levels and ensure stable kidney function and outcomes as well. Thank you.
Thanks, Ajay.